I'm so incredibly honored to be here today. I'm just trying to take this moment all in. It's my very first visit to the Institute of Medicine. And when I began my PhD work in communication 15 years ago, my advisor at the time came to me and said, I just saw this thing with this woman named Diane Meyer, and she's talking about this thing called palliative care. And so it's very surreal for me to be here today, 15 years later, to share my work on a national level, and I'm just incredibly thrilled to be here. Of course, any work that anybody does in healthcare doesn't come alone. I want to acknowledge my longtime collaborator, Joy Goldsmith, who's at the University of Memphis. And she was a PhD student with me at the University of Oklahoma when we first began to learn about palliative care and began to think about studying palliative care communication. And then about 18 months ago, Dr. Betty Farrell recruited me from the University of Kentucky at the Markey Cancer Center to join her at City of Hope in the Division of Nursing Research and Education. And I had been working with Betty for a number of years, and since my move to City of Hope, I've really just kind of launched my work in the area of palliative care communication, and more specifically focusing on nurse training. So nurses are really at the front line of care. They have a very different communication role than physicians. And Tom talked earlier about training physicians to initiate starting conversations. Nurses do not have that role. They have a very different role. They're on the other side of that interaction and that dyad with patients and families. They get conversations initiated to them, and so they need to be prepared for those conversations. And oftentimes they're asked to translate what the physician has said and what they've heard or what they've read on the internet. So when we think about providing communication training for nurses, it's very different than a physician-based approach. We know that nurses, one of their key communication tasks is to provide education. We also know that they provide an immense amount of psychosocial support to patients and families. They are key mediators often between family members in making decisions about treatment, about goals of care. And we also know that they are advocates for patients and families, and often a liaison between other members of the healthcare team and the patient and family. So communicatively, their role is very different. Now, initially, 15 years ago, primary training for nurses in palliative nursing came out of our division at City of Hope and Betty Farrell's work with the Robert Wood Johnson Foundation to begin the End-of-Life Nursing Education Consortium. And to date, they have provided more than 170 courses to nurses across the nation and as well as internationally. The curriculum began as a core curriculum, and as nurses came and attended those courses, pediatric nurses said, well, we do it a little bit differently. We need a little bit more here. And geriatric nurses came and said the same thing. So the curriculum has developed into a number of different versions for specific nursing audiences. Most recently, a Doctorate of Nursing Practice curriculum was developed through an NCI R25 grant. And to date, they estimate that they have trained almost 20,000 nurses, representing, and my slide says 86 countries, but we can now make that 88 countries. Just yesterday, they trained a nurse from Scotland and a nurse from Iran in palliative nursing. So it's an incredible program that continues to grow. When we think about health literacy in palliative nursing, it's so much more than just access to palliative care, because I've identified that the nurse's role is very different. They are often asked to translate some of the complex medical words and abbreviations, processes, learning how to give medication at home or upon discharge. We also know that health literacy impacts quality of care. So patients who have compromised health literacy have a difficult time doing their own medications at home, so it impacts patient adherence. The latest reports out that show we have an aging population amongst our that are seriously ill patient population are aging. New studies out within the last week show that who's taking care of them? Most often their aged spouse as well. So it's a huge issue in thinking about just the quality of care. I really look at health literacy and nursing beyond just somebody's ability to read and write. So in our approach to looking at nurse training and health literacy, we also take into consideration that Deborah Rotter identified as oral literacy, and that is a person's ability to speak and listen. So commonly in palliative care, we have family meetings, we get the team together, we get large groups of people together. And what our research has found is that not all patients and families are comfortable communicating in a small group, let alone a large group where you have the entire healthcare team brought in. Just like some of us couldn't get up here and speak today, everybody has different oral literacy skills and comfort levels. So we want to think about it in terms of oral listening. And we actually put a lot of pressure, as Bob mentioned earlier, about our oral literacy skills, because we verbally ask people to provide their patient history, and we expect caregivers to also provide the patient's medical history orally. So there is a big need to look at oral literacy skills in palliative care. In the last 5 years, I had a wonderful opportunity to work with Dr. Deborah Parker Oliver at the University of Missouri. She's a social worker, and she got a large grant to video record hospice teams talking with patients and family caregivers using an online video platform. And as a communication researcher, it was like handing me the biggest chunk of gold, because I got to go in and look at what are these caregivers and patients and family members talking to their healthcare teams about. And since it was a larger RCT study, they also were able to do caregiver outcome measures on anxiety and quality of life. And so we were able to look at what was going on in these conversations. And one of the things that we found is that as the grade level of talk within the conversation, within the meeting, increased, the caregiver anxiety also increased. And that when caregivers had anxiety, they reported confusion and difficulty providing pain medication at home. And again, this was in a hospice context. I've already mentioned several times that when we think about health literacy and palliative care, we just cannot forget those family caregivers. Such a key role that they play in what we do. When we looked at interactions between family caregivers and healthcare teams, we found healthcare teams, and again, this was just specific to hospice, but could probably provide some suggestions and indications on the palliative care side, but team members use 6 times as many medical words to caregivers. So yes, we do have caregivers that can learn how to present to an attending, but those are far and few between with our family caregiver populations. The majority of words used were drug names, sometimes generic, sometimes brand. That was very confusing. We also found that 3/4 of medical words used were never explained. They were used in a very fast pace, so that when they were used, the conversation was actually at a faster rate of pace than other parts. And we found that caregivers didn't really respond, which does indicate there may be a lack of understanding. And as we heard this morning, one of the goals that we want to achieve for healthcare providers is for them to communicate with patients and families at about a 6th or 7th grade level. And I have a daughter who's in 6th grade. This is not easy to achieve. She's been my little guinea pig over the last year in learning how, what does that 6th grade look like? What does that look like? But in terms of training nurses, this is something that we need to address. And in terms of health literacy and palliative nursing, one of my goals is how do I train nurses to communicate with patients and families at a 6th grade level? So as my bio mentioned that Renee read, we have developed the comfort communication model specifically for palliative care. And it represents the 7 basic principles of palliative care communication. Our module on orientation and options teaches nurses to address health literacy, teaches them about health literacy, about cultural humility and addressing a cultural background. And specifically, one of the tools that we've developed in our curriculum is the Plain Language Planner for Palliative Care, because we teach that it is important, as Bob described earlier, to bring the voice of medicine and nursing and combine it down to the voice of what Mishler calls the voice of the life world. And so the palliative care, the plain language planner for palliative care, and we call it the PLP, was developed to translate common medications and symptoms into plain language. And we took the top 20 medicines from the World Health Organization, and we translated them and then tested them, making sure that they were at a 6th grade level. We also teach, as part of this tool, the essentials of plain language, and that is that you should use active voice, you should say the patient's first name or the caregiver's first name when providing directions. You should use second person, limit your jargon, begin to recognize what words are jargon. In some of the studies we've read in health literacy, the word oncologist and oncology is a very difficult word for many patients and family caregivers. And more importantly, to speak in short sentences. Our initial research with the PLP, we took 155 nurses. We asked them to provide, here's a scenario. Why don't you tell us how you would explain this medication and symptom to a patient? Then we would provided some education on plain language planner for palliative care. The tool is a resource, background on health literacy. And we found that they were able to integrate and use plain language following the educational session on PLP. And most importantly, we reduced the amount of jargon they used, and we increased active voice in their responses. So this is very promising for us. We've just now launched into our comfort communication training. In January, we held a comfort communication training for hospital-based palliative care teams statewide in California through the generous support of the Archstone Foundation. We provided them with PLP training as part of that session. And then we just received an NCI grant for the first national nurse communication training program. We're very proud of this. Last month, we trained 100 nurses across the nation. Again, they received part of the plain language planner in palliative care as the curriculum. In October, we'll be training another 100 nurses nationally. And the way that we've been disseminating this work specifically is we've developed a pocket guide that gets distributed at all of our courses. We have integrated it into our iOS app, which is free through iTunes, and it is called Health Communication. And then we have it available on our website, the Palliative Care Communication Institute, pccinstitute.com. And as a result of providing our training courses, it became very aware to us that we needed to expand our work, as this is just our initial part. So right now, we are in the process of adding additional aspects to the plain language planner for palliative care, and specifically, providers in some of our studies asked for oncology symptoms and side effects and medication side effects. So we are integrating that as part of the planner. And then also, we had an incredible need for it to be translated into Spanish. So next month, our app upgrade will include those two components, and as well as a Spanish version. And also, briefly, it's been mentioned, our textbook of palliative care communication. I'm the lead editor. When we went to organize that volume and put it together, it's the first of its kind. We knew health literacy had to have its own section. It had to have its own component. So we do have a health literacy section that includes 5 chapters. They're listed here. And many of our authors of chapters within this volume are in this room. So it's an incredible resource for providers that will be out in October. And I've listed my references. Thank you.